Welcome to the Walden Find New Inspiring Scholarship and Social Change Symposium Series for August 2020. I am Megan Argerbright, the Education Committee Chair for the Sigma Phi Nu chapter. We have an excellent speaker this evening, and before we get started and I introduce her, we will cover some housekeeping items. This session is jointly provided by Walden University and Sigma Phi Nu chapter. The planners and presenters of this nursing continuing professional development activity disclose that there are no relevant financial relationships with commercial interests. No relationships exist for the nurse planner or presenters which could influence the planning or implementation of this activity. The planners and presenters have disclosed no financial interests or receive any in-kind materials that could influence the presentation of this material. To obtain your contact hours for this presentation, you'll go to the Walden University Continuing Education System and follow the prompts there. That brings me to introducing our wonderful speaker for this evening, Natasha Pruitt-Savage. She is originally from New York, but moved to Maryland in 2000 with her husband and son. She's been married for 21 years this September. Since moving to Maryland, she has specialized in women's health, starting first in labor and delivery for 7 years, then postpartum for 10 years. Natasha transitioned to Kaiser Permanente in the obstetrical and gynecological care outpatient clinic while still working part-time in postpartum to maintain her clinical skills. Kaiser Permanente offered the opportunity to train as a lactation consultant, so Natasha took them up on that. In 2017, she completed her baccalaureate degree in nursing. Just 1 year later, Natasha decided to pursue her master's degree in nursing informatics. She is now the lead nurse in her department and works part-time as an internationally board-certified lactation consultant. Welcome, Natasha.
Thank you for that introduction. Improving breastfeeding rates in communities with health disparities, utilizing video conferencing in the postpartum phase. Our objectives of this webinar is to bring awareness of the breastfeeding rates in women with health disparities, understanding how breastfeeding improves.
Miss Natasha, we've lost your screen.
Oh, okay.
Just go ahead and share and we'll go on with the show.
My apologies. Okay, the objective of the webinar. The objective of this webinar is to bring awareness of the breastfeeding rates in women with health disparities, understanding how breastfeeding improves health outcomes for the mother-baby dyad. We'll encourage the healthcare professionals to educate patients, families, and communities. Utilizing telehealth, such as video conferencing, can improve support and guidance to increase a mother's confidence with breastfeeding. Telehealth in the past has been utilized to provide to patients that live in rural areas that had no healthcare specialties locally. During the pandemic COVID-19, telehealth has emerged secondary to decreasing in-office visits to limit the spread. Utilizing video conferencing for breastfeeding education ensures the patient has support without leaving their home, and their family can be involved to continue the support the mother needs. Telephone conferencing creates barriers to visualizing the latch, position, and assessment of the breast. Face-to-face conferencing gives the support of verbal and nonverbal cues as if the patient was in the office. This service is essential for mothers with the lack of resources There are obstetrical and pediatrician visits that are necessary to attend. If the patient must choose which is more important, lactation is the least of their worries.
Hey, Miss Natasha,
Yes,
I haven't seen the slide change. There we go. Thank you so much.
not a problem. What is telehealth? Telehealth is a way of providing care via telephone or video conferencing. The patient must have access to a smartphone or a computer. The provider sends a link to the patient. It can be done outside of an organization where there is internet access. Telehealth is a way to provide care with the patient not coming into the office to receive health care. Most people have access to smartphones and the internet service to participate in this type of care. Prior to the pandemic, some organizations would have the patient go to a specific facility to access their provider. With the upgrades, patients are sent a link and they just click the link and the session will begin. Prior to the pandemic, providers have had to establish care with the patient before having a video conference, and they couldn't give care across state lines. Telehealth bridges the gap between patients with little resources but in the need of teaching, assessments, and diagnosis to improve health outcomes. Benefits of video conferencing. Banbury et al. 2018 explains patients don't have to be technical savvy to participate in video conferencing. Interactions are visible to both patient and provider. It's convenient for the patient with limited resources. Patients of all ages can participate on the simplicity of gaining access to the conference. It is vital to ensure a baby has a good latch if the patient complains of pain or to diagnose yeast or mastitis. The earlier you assess a problem and solve the issue, the longer the patient will breastfeed. Patients sometimes have a hard time describing issues, which lead to a delay in care. Visualizing issues with breastfeeding decreases the chance of the patient stopping before the 6th month or starting to supplement with formula. It can be done in a group setting or in individual access. The actual act of breastfeeding can be observed. Demonstrations are visual. The patient can perform return demonstrations. Video conference can be done to teach a group of patients or on an individual session. Getting support from peers is helpful to sustain breastfeeding. The group sessions give normalcy to the issues of the concerns a mother may encounter during lactations. Patients have participated in video conferencing found that it's similar to an in-office visit and would be open to having care in this manner, according to Banbury 2018. This type of visit validates the act of breastfeeding and is done correctly and can give confidence to the mother. Mothers are open to learning video conferencing for education on breastfeeding. Habibi et al., no date, explained preferences wasn't based on their scholastic aptitude, era, or the number of children, but on the enthusiasm of breastfeeding. Habibi et al., no date, explains that learning styles of the mother may affect the perception of video conferencing. If a patient is hands-on, then she can demonstrate breastfeeding. Patients that learn well with observation can adapt easily to this type of visit. This type of visit gives verbal and nonverbal cues. Patients are motivated to breastfeed are accepting to learn and receive instruction in this manner. The rates of breastfeeding in women. White non-Hispanic initiate at 85.5% and exclusively breast 2017. Hispanic initiate at 81.9% and exclusively breastfeed at 18% for 6 months, according to CDC 2017. CDC 2017 demonstrates that non-Hispanic women lead the way in initiation and longevity with breastfeeding. Women often complain about the lack of support. In PG County, Maryland, which is predominantly African American population, have no La Leche League to support breastfeeding in that county. The lack of support from peers and professionals will keep breastfeeding rates at low longevity rates. Barriers to breastfeeding. Friesen et al. No date explains absence of lactation support from healthcare professionals. Pain during breastfeeding is a common obstacle. Returning to work at 6 weeks postpartum, inadequate milk supply, and lack of knowledge concerning benefits. Obstacles that women face during the postpartum phase with no support from family or healthcare professionals lead to pain, which becomes unbearable if there is no solution. When patients are in pain, it leads to supplementation. Early supplementation leads to inadequate milk supply. If the breasts are not stimulated 8 to 10 times during a day, your body automatically stops making breast milk. Breast milk supply is based on stimulation from breastfeeding, hand expression, or pumping, unless the patient has medical issues. Mothers with low socioeconomical have jobs that don't support breastfeeding with rooms to pump, storage for the milk, or the time to allow them to pump, according to Louise Jacks et al. 2017. Some patients complain that they didn't get seen by a lactation consultant if they deliver over the weekend or only stay in the hospital for 24 hours, which limits their knowledge on the importance of breastfeeding. Leading cause of death. According to Haran et al. 2019, of 10 categories, the leading cause of death in the United States is heart disease, number 4 is respiratory disease, and number 7 is diabetes mellitus. Given that 2 of the leading causes of death in the United States, heart disease and diabetes, are linked to obesity, breastfeeding can help reduce obesity rates, contributing to those top causes of death, Haran et al. 2019. African American and Hispanic lead in health disparities, but have lower rates of breastfeeding in the United States, according to CDC 2017. Lactation conferencing gives reasons for lack of breastfeeding, such as free formula from WIC, hospitals giving gift bags at discharge, and advertisement that compares formula to breastfeeding. Formula is convenient for mothers that have to return to work, have painful latch, and lack of knowledge of how to tell if baby is getting enough. Teaching parents all of this information will increase the confidence needed to breastfeed. Benefits of breastfeeding for infants: decreased risk of respiratory disease, decreased risk of diabetes mellitus, decreased risk of certain cancers, increased immunity, decreased allergies, decreased risk of obesity, according to Louise Jacks, 2017. Breastfeeding has an array of benefits for infants that can be carried into adulthood. Formula-fed babies are overfed, which expands the stomach, and the baby will want to have the same feeling of being stuffed, which leads to obesity and diabetes. Increased immunity comes from antibodies the mother makes that's passed via breast milk and gives the infant passive immunity. Breast milk is easier digested and rich in nutrients. Benefits of breastfeeding for the mother: decreased risk of cardiovascular disease, according to Louise Jacks, 2017. Decreased risk of ovarian and breast cancer, according to Schwartz et al., 2017. Decreased risk of postpartum depression, according to Louise Jacks, 2017. Decreased risk of postpartum hemorrhage, again, Louise Jacks, 2017. Healthcare costs could be reduced, again, Louise Jacks, 2017. According to Schwartz, 2017, which suggests the lack of weight retention with breastfeeding lowers the rate of cardiovascular disease. Breastfeeding mothers have a decreased risk of postpartum depression since the hormone levels stay steady instead of plummeting after delivery of the placenta. The uterus contracts during lactation since your body will produce oxytocin, which reduces postpartum hemorrhage. The absence of your menses is related to low estrogen levels and increased prolactin. Some women don't get a cycle during their lactation duration. Decreased risk of type 2 diabetes, Schwartz, 2017 et al. Easier transition into postpartum phase since hormones level out without drastic changes, according to Schwartz et al., 2017. Breastfeeding increases metabolism when producing milk. A woman who eats appropriately will automatically lose weight and have a reduced risk of type 2 diabetes. When the placenta is delivered, the progesterone levels drop drastically and won't go up until the first cycle, which can increase the rates of depression. Breastfeeding elevates prolactin, which counteracts the low levels of progesterone. Recommendations for breastfeeding: exclusively breastfeeding for 6 months, breastfeeding for at least a year with introduction of foods at 6 months. Louise Jacks et al. 2017 explains that the recommendations for exclusive breastfeeding is for 6 months with no other liquids unless medically indicated. There should be no water or dextrose added into the diet. When working in the nursery in 2001, all infants' first feeding was dextrose water. Evidence-based practice has changed and no liquids except formula or breast milk should be given to reduce empty calories. The infant does most of their growing up to 1 year and need nutritious calories. According to Healthy People 2014. They also suggest that infants should breastfeed for 6 months, and they would like that to be at 60.6%. 34.1% will breastfeed for 1 year, And this is all according to Healthy People 2014. 46.2 will exclusively breastfeed for 3 months. 25.5% will exclusively breastfeed for 6 months. Healthy People 2014 have recommendations to improve health outcomes and decrease healthcare spending. HealthyPeople.gov 2014 are striving to improve health of women, infants, and children by creating objectives. Breastfeeding improves the health of mothers and the infant, especially for the population that have increased risk for health disparities. Healthy People 2020 objectives for the infant. 38% of employees will offer breastfeeding support rooms. Reduce supplementation of breastfeeding by 14.2%. 8.1% of facilities will provide recommended care for mother-baby diet with lactating. And this is according to Healthy People. HealthyPeople.gov 2014 suggests not only encouraging breastfeeding, but to get the community involved. Having privacy and breaks for breastfeeding encourages mothers to have self-reliance to pump and continue breastfeeding after returning to work. Having lactation support at the WIC office instead of just offering formula and educating parents on getting healthy food instead of formula. Patients think if they are breastfeeding, they can't have WIC benefits. Awareness to increase breastfeeding rates. Lewis Jacks et al. 2017 suggests self-efficacy is the dynamic reason for not successfully breastfeeding. Cultural and racial disparities exist in healthcare which affect long-term breastfeeding, according to Louise Jacks, 2017. Fostering knowledge based on literacy and language, according to Jacks and Lewis, 2017. Health professionals that are aware of the barriers will emphasize and become more supportive in the pre- and postpartum phase. Having group video conferencing ensures women that they are not alone and that they get to visualize people of their race and cultural background. Ensuring literacy and language aren't a barrier to increase breastfeeding rates. Assuming patients have knowledge on breastfeeding because their parity creates barriers to healthcare professionals. All patients need the same information unless advised that they are aware of the facts.
3 minutes.
Healthcare professional tips. Policies in place for breastfeeding mothers, ensuring all staff is trained on lactation, every patient has education on breastfeeding, mother-baby diet are kept together unless medically necessary. Staff will encourage breastfeeding on demand and only use formula when medically indicated. Jack Louise 2017 suggests policies should be in place to encourage breastfeeding. This will ensure patients get the same care across the board. If all staff is trained on lactations, patients don't have to wait to get started breastfeeding or pumping when necessary. All patients receive the same facts when taught by different staff members to decrease confusion. When organizations have rooming in, infants can breastfeed on demand, decreasing the use of formula. In conclusion, expanding the use of technology and lactation with video conferencing will promote and support the education of breastfeeding to improve health and reduce costs in healthcare. In conclusion, using telehealth can increase the support that is needed to help mothers with health disparities and socioeconomic issues. This platform can be offered in group setting or an individual basis. The patient has the convenience to be at home with the baby and receive support visually to prevent issues before it interrupts lactation. Giving the knowledge of breastfeeding and health disparities, breastfeeding could reduce the cost of health care by over $3 million per year, per Louis Jacks 2017. Decreasing barriers will help support longevity of breastfeeding. References: Banbury et al., 2018, Lactating 2010, Centers for Control and Disease Prevention 2017, Clip Art 2017, Friesen et al., no date, Habibi et al., no date, healthypeople.gov 2014, Haran et al. 2019, iStock 2015, Louise Jacks 2017 et al., Rohimi, no date, and Schwartz et al. 2017. Thank you again for your time and your attendance.
Thank you so much, Natasha. We really appreciate your presentation. We have a few questions for you. I'm just going to share the screen really quick. Hold on. Okay, so our first question for you is, what tips do you have to increase engagement when using video conferencing?
When using video conferencing, it's very important that you have good lighting, you look professional, you have no background noise, there is no disturbing colors in your background or family members or anyone coming in. It's important to use hand gestures. It's also important to make sure that you use facial gestures to engage the patient. Use demonstrations and ask the patient to demonstrate back to you. Make sure that you have things like a baby so you can show them position. Make sure that you have bottles, a boppy, so that you can actually demonstrate to the patient what you would like them to do. You want to make the experience like it's a face-to-face visit.
Wonderful. Our next question, how do you encourage confidence in a breastfeeding mother?
When doing a video conference, it's important to involve the family or the partner so that when the conference is over, they can also remind them of information and help to support them, because that's one of the goals, is to have your family help. Also, give praise to the mother for attempting to breastfeed. Also, tell the mom what the health benefits are. Tell the mom what the health benefits are for her and for baby. And then you want to also let her know that the cost of breastfeeding is zero. You want to also give examples if she's experiencing something that another patient might have experienced. You want to bring that up so you can just let her know what she's feeling is very normal.
Great advice. What do you teach a mother that didn't receive consultation in the hospital?
It's very important to go over position. It's also important to tell the mother what to expect from baby. How many times should the baby eat within a 24-hour phase? What should the output be? Because a lot of times moms don't see any milk until day 4. So they're thinking the baby isn't getting enough. So you want to let the mom know each day what to expect from stools and urine. Also, talk to mommy about engorgement, because that is going to be painful, and pain also stops mom from continuing to breastfeed. And also tell them about baby's loss of weight, because sometimes when you go to the doctor on the first visit, baby may have lost 6% of body weight. It's normal to lose up until 7%, because fat is not added until the breast milk until about day 4 or 5. So baby doesn't start to gain, they lose until that fat is added.
And then our last question, how has COVID-19 impacted your role as a lactation consultant?
COVID-19 has really impacted the breastfeeding, because a lot of times if mom is positive for COVID-19, she's afraid to breastfeed her baby. She's afraid to handle the baby. So what you want to do is encourage mom to always wear her mask, do good hand washing, and breastfeed the baby, because the baby is now getting antibodies that help to protect against infection. And don't alienate the mother. Let the mother know that you are there to help them even though this infection is present.
Thank you, Natasha. That was wonderful. Our next speaker is Christy Atkins. Christy, go ahead and take it away.
Thank you. My name's Christy Atkins. I'd like to welcome you to Why Atella ICU. The introduction of technology in the ICU as a virtual consultant's been around for about 50 years, but it wasn't until the novel coronavirus and the ensuing COVID-19 pandemic pushed for social distancing and self-quarantine that telehealth really took off. To prepare for the surge in ICU patients related to COVID, some facilities developed or added a tele-ICU to support staff and patients. Some facilities already had this in place. My name's Christy Atkins, and I've been a nurse for about 23 years. Most of that time's been in the hospital setting. I graduated from Wright State University in 1996 with my Baccalaureate of Science in Nursing, and I currently working on my Master's of Science in Nursing with a focus on nursing informatics. I'm a member of Sigma Theta Tau International Phi Nu chapter, and I'm a member of the American Nurses Association, Ohio Nurses Association, and American Nursing Informatics Association. Learning outcomes. Today I hope to educate you on the benefits of utilizing a tele-ICU. And as a result, I hope that you will understand and be able to articulate those benefits to others when you return to your healthcare organizations. First, let's talk about telehealth. Did you know that the first continuous tele-ICU model began in 2000? That's 20 years ago, and acceptance has been slow. However, telehealth nearly doubled between 2010, when 35% of hospitals used some form of telehealth, and 2017, when 76% did. The American Hospital Association reported in 2017 that there were 6,000 critical care units in 3,900 hospitals across the United States. Some estimates say that in 2017, telehealth services reached more than 18% of ICU patients across the country. Dr. Susan Bailey, president of the American Medical Association, recently had an interview where she talked about telehealth in the COVID-19 pandemic. She said, "We've gained 10 years of telehealth experience in 10 weeks as an industry." Let me say that again. We've gained 10 years of telehealth experience in 10 weeks as an industry. Did you know, if primary care doctors could reduce emergency room visits by utilizing telehealth options in their practice, if they could decrease emergency room visits by just 1%, the average emergency department would save $101,920,000 per year. Think about that. 1% difference could save over $100 million. United Healthcare advertised late-night commercials aimed at young parents. They suggested using their telehealth line from the comfort of their own home to parents whose baby might be ill and save a trip to an urgent care or an emergency room. How smart is that? The insurance company saves big bucks advertising to millennials who are comfortable using video chat on their smartphones. The tougher sell, however, might be to adults who aren't comfortable using video chat or those that do not have a smartphone. So, what is a tele-ICU? According to the American Association of Critical Care Nurses, the definition of a tele-ICU, also known as an EICU or a virtual ICU, is a collaborative interprofessional care model associated, or excuse me, focusing on critically ill patients that are enabled by leveraging audio, video, data, and other technologies to engage critical care experts in patient care, along with clinicians at collaborating sites. And services may be expanded to include other high acuity or progressive care patients. Okay, so what's that mean? It means that interdisciplinary care teams, the constitution of such teams depend on the organization's need and the state's regulations for practice. The teams comprised of physicians, physician assistants, nurse practitioners, expert critical care nurses, pharmacists, respiratory therapists, information technology representatives, and administrative support personnel who will work together in collaboration with a hospital's bedside staff to monitor patients and provide patients with the best evidence-based care that's available. This is a wonderful example of teamwork. The patients are the focus and the staff feel supported. Did you know that tele-ICU physicians, also known as intensivists, and the expert critical care nurses can prevent patient deterioration by recognizing declining trends early with their clinical decision support system algorithms and notify the bedside staff of what's occurring. The tele-ICU physician or other advanced practice provider can run the code for a code blue until a physician is physically present in the room and able to take over that code. And in addition, the tele-ICU nurses can scribe for that code blue. Isn't that great? How many of us would love to have that piece off of our plates during a code? Slide 8. Significant education needs to take place prior to bringing in the concept of a tele-ICU in your organization. A culture of change acceptance needs to be laid. Staff need to understand what their function is and what the tele-ICU staff function is within the critical care team. Some staff can feel threatened, angry, scared. Communication is essential so that the message of collaborative patient care is heard. Expectations for teamwork must be set to reach the common goal of excellent patient care. Collaboration is crucial for the successful implementation of a tele-ICU. So what a tele-ICU is not, they're not there to watch over your shoulder. They're not there to monitor how you're doing your care or wait for you to make a mistake or to report you if you do something wrong. They're not there to nitpick every single thing that you do. They're not Big Brother. Let's talk about nurses for a moment. And this can apply to other ICU staff as well. Physically stressed. Plastic gowns can cause heat stress when you're worn for long periods of time. Dehydration from wearing all this PPE make nurses not want to drink, eat. They don't want to go to the bathroom while they're in PPE. They may feel like they can't because of exposure risk or because they don't want to waste PPE. They can be fatigued from long, hard, physically taxing shifts. They can be mentally stressed. Circulating air from the negative airflow fans can cause excessive noise, which can hinder the ability of nurses to hear alarms and cause overstimulation. Nurses become overwhelmed, overworked. There's more frequent, longer shifts as the number of patients increase. and the number of nurses decrease because you have nurses out for illness, you have nurses out because they're just burnt out and they leave the profession or they leave the ICU. Emotionally stressed, providing care and offering words of comfort to patients who are dying, often without family in this COVID pandemic, can take its toll on nurses as well. They're providing emotional support to patients who are alone, scared, and critically ill. We have our own anxiety and fear of the unknown status of patients because some patients are asymptomatic. We are separated from our families because we don't want to be the ones to bring this virus into our own homes. Some nurses are being floated to units outside their comfort zone. For example, OR, PACU, clinic nurses can be floated to maybe a med-surg nurse, or a med-surg nurse could be floated to a critical care unit. They feel undervalued. Sometimes they're not given much support in those areas, and nurses, like I said earlier, can leave the critical care area just because of all of these factors, and that leaves fewer expert critical care nurses for us. So how can we alleviate some of this stress? Tele-ICU is the answer. They have your back. They can be there for you as that second nurse, so you have less donning and doffing, less risk of exposure, less PPE use, less stress. And they're there to work with you as a team to help support patients to get better and to stay stronger so you don't have that deterioration. That improves nurses' quality of life in the workplace. Positive effects of an EICU. They provide monitoring for the prevention of decline. They provide diffusion of evidence-based practices. They deliver expert guidance and support to bedside nurses. And perhaps for those young nurses or those new to critical care nurses, they could deliver that expert guidance and support as a mentor. But if you have an experienced critical care nurse, even they can contact the tele-ICU staff to discuss, hey, I'm thinking maybe this is happening, or this is what I'm seeing, what do you think? And get that collaboration for support in their decisions. They perform data collection, analysis, and quality reporting. They do improved patient outcomes as a result of this. They're seeing patients who are doing better, and they're decreasing the length of stay with the implementation of tele-ICUs. Okay, so they are monitoring CDS algorithm alerts for deteriorations based on trends and on single data points. When an alert alarms, the tele-ICU staff can camera into the patient's room to see what's going on. Perhaps the patient is getting a bath and the alarm was simply just artifact and not really a true alarm. Perhaps the alarm is a patient crashing that wasn't noticed because ICU staff are tied up with a new trauma admission to the ICU. Williams et al. In 2019 reported that a tele-ICU leverages technology to bridge the chasm between increasing ICU patient volume and the limited resources of expertly trained critical care nurses. So let's delve into this a little bit further. Nurses, we want to know how this is supposed to help our patients. What are the nursing sensitive measures? Pressure ulcers, restraints, falls, catheter-associated UTIs, central line catheter-associated bloodstream infection or CLABSI, ventilator-associated pneumonias, sepsis prevention, length of stay in the ICU, length of stay in the hospital, discharge locations. Those can all be things that are affected with the addition of tele-ICU. With the addition of the monitoring and the algorithms, patients' outcomes will improve. The quality of care that our patients receive is better. Deterioration is caught sooner. Patients are staying healthier, and that means shorter ICU stays. Shorter ICU stays mean lower healthcare costs. Per an independent Center for Medicare and Medicaid Services audit, excuse me, Emory saved approximately $1,500 per patient per encounter. And when that's extrapolated over the 3-year period that they were monitoring for their Healthcare Innovation Award grant, that means that they saved approximately $18 million by having a tele-ICU in their healthcare. They're in their ICU. We also want to know how it helps the ICU staff, the bedside staff. And number one, they have another set of eyes on patients. That's about teamwork. That's not about competition. With the goal of evidence-based care, quality patient care. We all want that for our patients. The second thing is increased ICU patient volume can lead to using non-critical care nurses to come into the ICU and help. Or sometimes those ICU patients stay on those med-surg floors, so you don't have the experienced staff. You have the med-surg staff who are trying to accommodate those critical care patients. So they need mentoring, they need monitoring, and they need support. The third thing is you have improved job satisfaction for on-call intensivists. If those intensivists that are on call can get better sleep, you have better brain power when they are awake, right? So you want to make sure that they're able to get that sleep. The tele-ICU can answer most of those situations or questions for nurses because a lot of them have advanced practice physicians, advanced practice providers or physicians, along with those expert critical care nurses to help you. So the ICU nurses, extra support means less stress and more happiness in your job performance. How many nurses have gone home after a rough shift and they were angry or they were upset because you couldn't give the quality of care to the patients that you wanted to give for whatever the reasons were that night? The tele-ICU offers ICU nurses that extra help, that extra set of eyes to monitor, that extra brain power to evaluate the patient data, those extra interventions to improve your care. They are the extra support that's there for you, the bedside nurse, to give the best care possible to your patients. With isolation patients, especially important in this COVID-19 pandemic, those patients, tele-ICU nurses can check the amount of IV fluid remaining, they can check drip rates with you, they can check vital signs on the monitor, vent settings, or even be that second nurse verification for things like blood transfusion or medication administrations, and that saves time. You don't have to go out looking for a second nurse to come in, and it saves PPE because that second nurse doesn't have to use another set of PPE to come in and do those things with you. You have the tele-ICU staff doing that with you. So in summary, tele-ICUs help healthcare organizations meet quadruple aim. So by meeting the quadruple aim, you're reducing healthcare costs, you're improving population health, you're improving the quality of care for your patients, you're enhancing your staff work-life experiences. And by meeting these aims, we can meet the standards that are required for Joint Commission certifications, standards for magnet criteria, and standards for the Center of Medicaid and Medicare Services and other insurance companies' criteria for the reimbursement of your services. All of this means more money for the hospital, better outcomes for the patients, high patient satisfaction, better job security for the staff, and improved job satisfaction for the staff. So, is your organization now ready to join the table and talk about tele-ICUs? Dr. Craig Lilly is the director and founder of the ICU telemedicine program at the University of Massachusetts. And Dr. Lilly has been at the forefront of tele-ICU adoption. He hails telemedicine as one of the most potent tools available to healthcare systems and to patients. Commenting on the use of artificial intelligence in critical care, such as in the tele-ICUs, he said, and I quote, "Rather than reacting or having alerts and alarms in the room that tell us that a patient is deteriorating, we can know ahead of time so that we can intervene in a way that prevents the patient from ever having any symptoms in the first place. It's truly an advance," unquote. So we need to bring people to the table. We need to bring our organizations together and talk to leadership about why we aren't using this kind of technology and using these tools within our critical care settings. Recently, the Society of Critical Care Medicine has decided that tele-ICU is not even the encompassing enough term for what we do, for what the tele-ICU does. And they have gone to calling it the telecritical care instead of tele-ICU. And it's being hailed as the new gold standard of care, which is kind of a paradigm shift. You have the 24/7 intensivists available, where some models may only use a doctor on off hours or on weekends or holidays. But if you do the 24/7 availability of a physician with those critical care expert nurses and perhaps other staff, then you are really at the gold standard. Using those algorithms will provide the best patient care. So now I'd like to open it to any questions.
Thank you so much, Christy. That was wonderful. We have a few questions for you. Our first question is, have you heard about Emory Healthcare's eICU in Atlanta, Georgia, and their counterpart in Perth, Australia?
Actually, yes, I have. Their program is being announced as the first of its kind. Director Cheryl Hiddleston developed this concept to address a couple of issues. There was a shortage of critical care staff willing to work the night shift, which we all know people don't like to work night shift. And especially having that experience on night shift is difficult as well. And to decrease the physical and mental stress of working night shift, because we've had studies that have shown us that night shift is not good for our bodies, they developed a program where they pay their staff to relocate to Perth, Australia for a period of time. And generally they do 8 to 16 weeks at a time. They go to work in Perth, 7 a.m. Perth time, which is Georgia time, 7 p.m. They work a 12-hour shift, day hours, so their bodies like that much better. And they still have their nights and days off to go explore anywhere in Australia or the surrounding countries. They can explore the world. And it's been a huge success.
That's awesome. Our next question, in what other areas can telehealth be utilized in the hospital setting?
That's a great question. So telehealth has been used for consults to mental health, to behavioral health, neurology for strokes. It's been used in the neonatal intensive care unit for infant arrests or neonatal arrests. It's been used in dermatology for a multitude of skin issues. And there's so many more places. Telehealth can be brought into the critical care areas that I was speaking of, also in addition to ICU, places like the emergency room, the post-anesthesia care unit or PACU, the MICU or the medical ICU, the SICU, which is the surgical ICU, the CVICU, which is the cardiovascular ICU. They can be used in life flight and so many other places. You can use them in progressive care and primary care and on and on. There's just not a definite end. It can be adapted for anywhere.
That really is amazing. Our third question and final question, what steps can an organization take to gain staff acceptance of a tele-ICU?
So the very important thing here is to lay that groundwork and make sure that staff are going to be accepting of bringing in the tele-ICU. You need to educate them about clear roles and responsibilities for what the staff will do and what they're responsible for, as well as those roles and responsibilities of the tele-ICU staff, so that we don't have someone saying, well, I thought they were going to do it, or it's put off on someone else and gets dropped through the cracks. You really need to make sure everyone is accountable for their responsibilities and their roles. And then you need to establish those relationships between the tele-ICU staff and the bedside staff. And one way to do that is with a liaison, perhaps assigned either from the bedside staff end or from the tele-ICU end, or perhaps both, just so that they can keep in touch and have a point person that they know they can go to if there's an issue. They can be included in maybe unit council meetings or other meetings to keep abreast on what's happening in that area for them. You need to set expectations with the ICU staff and begin early in the project with those informal leaders in the ICU. So when you're bringing in this concept to the ICU, those people that are pushing the loudest, those people who are those leaders that everybody goes to for direction, those are the ones you want to bring in, especially early, to kind of get them to understand what the benefits are and what the reasons are, so that they accept it early on. Because once you have their acceptance, the followers will come around as well.
That's great. Wonderful presentation. I'm going to go ahead and steal the screen back here. All right. We want to thank our speakers for this symposium series and remind you to get your continuing education credits through the Walden University Continuing Education System. Thank you and have a great day.